say a very warm welcome, first on Mao, to our new Deputy Director of Public Health, Hugo van Beurden, who's sitting at the back there. Hugo's returning to Wales, coming back to us from Scotland, very well known to those in the world of public health, not just in Wales, but at the UK level and internationally. Adele has done brilliantly in persuading people to come back to us. So, very warm welcome. I'm going to sit in and observe the afternoon. Hopefully, definitely be with us in January, but hoping to squeeze your way in before then. Super. So let's reconvene then, and we're on 4-1, and Andrew, DDRIC.
Thank you, Jan. There were 3 alerts at the last meeting, 2 of them concerning information governance. The first of those was related to subject access requests, and committee members noted that further work was required to reduce the risk level for subject access requests. But there were possible things to do, so we asked that an action plan be put in place to accelerate the mitigating actions. The other IG risk was highlighted by the Information Governance and Cybersecurity Assurance Group, but actually was the same risk, but expressed from a GDPR point of view. So recognising that it was actually the same solution, that made it all the more important that we had the mitigating actions that would reduce the subject access requests delays. The other alert was to note the need for continued oversight of the digital strategy and plan, largely because of a number of risks outside the health board's control, and those risks could introduce delays into the overall digital strategy, particularly related to LIMS, PACS and maternity. However, you will also note that we took assurance on the digital strategy and the plan, because we received the first version of the plan and the page, which showed all the activities in one place, that we could see what the plan was for the year, along with the resources necessary, and it gives us the basis to be able to be assured that the plan is working out, and if it's not, we will get early sight of that to be able to give the board assurance or otherwise. We also took assurance from the Business Intelligence Audit Report, which had a substantial assurance rating, and we also noted the programme on the to digitise eye care services, and particularly noting the emphasis on the regional scope of the work and the opportunities that that would give us in terms of service change going forward. We have a future meeting scheduled, particularly as a briefing session to bring us up to speed on information in terms of the dashboard use across the organisation, as well as what we are currently doing in terms of AI and the governance around AI. So that's to bring the committee up to speed so that we have a base level of understanding, and also around what is the art of the possible with regional working, both for digital but also for research as well. So we're holding that meeting, and then we've rescheduled the following meetings to be a little bit more timely and in line with the board meetings, that we bring in a better update on the digital strategy to this board meeting. So that was really it. I think probably Dee, you might want to add.
Thank you, Andrew. Yeah, so specifically on the GDPR and the SARS alert, I'm pleased to report that an action plan has now been implemented, and the procurement of some software to expedite the collation of that data, which will culminate from emails and a myriad of digital clinical and administrative systems, is underway. We expect that software to be in place by December and to be running, and we will take an update of the action plan and the procurement back to the DDRI committee. If I could, though, I'd just like to, I guess, reflect on the ministerial priority about patients having access to their own information, not just for SARS requests, and I suppose just recognise the work that we as a health board have done with our digital, clinical and operational teams to expedite the NHS Wales app. So we have by far the most significant number of users across Wales. So we now have 25,000 patients who not just use the app for the services that have been launched by the Minister, but we've expedited that work in Swansea to share blood results, clinic letters, appointment letters, to empower those patients to manage their care closer to home. And that has also been built into the plan from a SARS perspective, so that it's not just a SARS requirement to share information, but you know, it's the right of these patients and citizens to have access to their own information to support their care, and importantly for their families to support their care with them, as well as their clinical team. I'm also pleased to report that since we've published the report, we've gone live with Open Eyes, the ophthalmology EPR, which is a significant step forward for NHS Wales. That will be a key enabler to the work we're doing on regional eye care. Hywel Dda are very much in the readiness stages of that work, and we're supporting them on how they can plan for their configuration through resourcing and regional ways of working, along with Deb and her team through the Planned Care Board. And I'm also, you know, we're very conscious of the pace and the ambition of the diagnostics programs. We talk about that at length in our DDRI committees. But again, just reflecting on some of the papers later in the agenda, CellPlath, we're the first health board in Wales to put our hands up to go live with cellular pathology as part of the LIMS replacement. And the current schedule is for that to go live in Swansea as First Health Board on the 10th of November.
That's a great update. Thank you. It's really heartening to hear all that. Deb, you come in.
Thanks, Chair. Just on the Open Eyes bit, so huge thank you to Dee and the team for getting us on live on schedule. So we agreed as a region we would go live with Open Eyes in September. It is disappointing that Hywel Dda hasn't been able to do it alongside us, but hopefully they can expedite their implementation now. They've given us the backdrop of end of March 2026. But with our learning, hopefully they'll be able to expedite that. So that's going to be the latest go live date, and then hopefully they'll kick off where we go from a regional perspective, because it's pivotal to that work.
You know, let's hope they can accelerate with our assistance. Thank you. Any comments or questions for Andrew or Dee? No, we can take assurance, Andrew, and thank you and team the committee very much for your diligence in taking us through the agenda. So Jean, shall I turn to you now, please, on quality and safety?
Thank you, Chair. I gave a verbal update on the outcomes of the July Quality and Safety meeting. So unless anyone wishes to raise anything from that, I'll move straight into the 11th of September meeting. And the alerts that we were bringing to board were from the Quality and Safety Group exec summary, which we now receive at every update from the Quality and Safety Group exec. We receive an update at every Q&S meeting. So the staffing levels in the prison service were reported, and the committee was advised that these levels would be reviewed as part of the wider community services review, which then will include benchmarking data so that we have a better understanding of what that resource would look like. The next alert was the healthcare acquired infections, which we did raise an alert on in the July meeting, and the committee wished to alert the board that no measurable improvement in rates of C. difficile, in spite of considerable efforts, had reduced the rates. The stroke services was the next alert to advise that compliance against the 4-hour access target and ring fencing of beds for admission to acute stroke still remains challenging. Work is underway to improve the flow between Morriston and Neathpool Talbot hospitals. Funding has still not been received to implement the 24/7 consultant rota. However, we would assure board that continued high compliance of thrombolysis rates, swallow and therapeutic assessments is being realised, and the stroke performance plan has now been revised, which I don't know whether Leslie or Deb want to come in on that later. But we do wish to alert the board to the lack of performance against KPIs, the national targets in particular, in the increase of mechanical thrombectomy, a priority in reducing door to needle time for thrombolysis is an area for improvement as well. And the last alert, well, the penultimate alert, because I have another one as we go through the perinatal committee report, but the penultimate is the health and safety and fire report that we received, as the number of outstanding actions relating to the fire risk assessments, and recognise that none of the actions were in the high risk category and that they were being monitored routinely. However, The committee wished to alert the board to the risk of blocking of fire exits by beds, which was still ongoing. So shall I move to the perinatal, which contains the other alert, or would you like me to pause there?
Right, we can pause there, Jean, so we can pick up the alerts to date, if that's okay. And Deb, if you think about stroke and outstanding fire service action, but Richard, can I ask you to talk about this and HCR, please?
Thank you, Jean. And it's an opportune moment to pick it up here. This report where there'll be some more information. So this is a real concern for us. If you look at the dashboard progress against our TI goals, not achieving either monthly or quarterly targets against the full principal infections that are considered as part of the hospital associated criteria. They're all very different in the way that they're acquired. Some of them through skin, some of them by contact, some of them are high risk through catheters or intravenous devices. This was the one that's of most concern in C. difficile because it can be transmitted in hospital. It's certainly the case with C. difficile that, and preface that by saying, in terms of C. difficile, two things. First, that we're the health board with the highest rated C. difficile cases in Wales and one of the highest in the UK. And on a background of all of healthcare struggling with C. difficile post-pandemic, it's been a general policy influence. In terms of the cases, we're now able to diagnose in a much more sophisticated way. And because we're able to do the genetic testing, we're now able to tell, for example, if somebody, if we tested a sample and we're able to do the genetics on the C. difficile, but we're now able to tell whether you're linked to an exposure to a patient who came in several weeks or several months ago. It's not necessarily the case that that transmission event occurs when you're in the same bed next to somebody who's got C. difficile. That could be several months hence. But I suppose what that represents is not necessarily things that happen in the here and now, but our environment, the spores of C. difficile, then in the environment. So in terms of what we're doing well on, there are some aspects of this in terms of the actions. Antimicrobial stewardship, we do really well. Compliance with guidelines on antibiotic prescribing, we do very well. And we often review antibiotics at 72 hours to see whether they should be switched to intravenous, from intravenous to oral medication. Our audits would tell us that certainly in some areas we do well on the basics of things like hand hygiene when we do those audits that are self-reported. But despite all that, it doesn't seem to be getting traction, which is a real concern. There are two things I think, so in reforming the IP&C group and particularly working with the IP&C team around C. difficile, we've set up a high incidence management group, which will give much more timely response. We're setting new C. difficile standards with a risk assessment and governance framework, and that's been rolled out. I've initiated a small scale project on that 72 antibiotic review, which is where we review them really well, but we actually don't act on anything. So to make it easier for people to make the switch of antibiotics, and we're hopefully going to get some funding for that from our government. The main thing that's of concern is our that's probably the thing that's impacting most. We know that we are we're over bed capacity. So in other words, in the way that we manage flow, we've got more patients than we should have. We don't have enough isolation facilities in our main hospital buildings. In other words, somebody comes in with symptomatic diarrhea. We don't know if it's C. diff yet. We should be isolated. We don't have sufficient rooms, and we don't have the ability to decamp towards the point where we get an outbreak. So the IP&C team, for example, were telling me about, I was relating that about the cases that happened several weeks or several months hence. There have been instances where there have been a few days since in a transmission. It's been related to us not being able to clean facilities and properly between those patients arriving in. So there's some real challenges for us then in how we take that forward. We know that we're not up to the cleaning hours at Morrison Hospital that we should have. Added to that, there are new cleaning standards for 2025, which are actually going to be a challenge for everybody to meet those standards, but it's even more of a challenge for us. So for me, there's a few things. There's the pushing on the standards. There's the ensuring that we're doing the basics as well as we think we are. And then thirdly, just to look, I think we need to look again at environment. While the benefits of the unscheduled care programme and what we're seeing at the front door being fantastic, that means that we're not having patients fishbone down the centre of ED. Those contact points have now gone. We do escalate through the wards. We've got more patients on the wards. I would hope that as that gains traction and as we get improvement in that, what that will result in, as well as the clinically optimised patients and progress on that, is it will depressurise our wards. We've depressurised ED. We now to depressurise our wards, so our bed occupancy is where it should be, and that will allow us much better traction than hopefully, in due course, to have that decant facility. But I think we need to do more on that. It's cleaning rooms, cleaning equipment, cleaning beds, and then making sure that we're doing the basics as well as we think we are.
So, Missy, can you oversee and tracking all the additional actions that we've outlined?
Thank you. If I move on, there's just one thing I wanted to pick up before.
Oh, hang on a minute, Jean, sorry. Deb to come in on fire escape blocking and stroke services, sorry.
Thanks, Jen.
Please come in.
I'll take the fire escape one first, because obviously that links in with Richard's update on the C. diff issues. So you'll be aware we did have some concerns raised about the use of patients in front of fire doors through the fire enforcement officer from South West Fire and Rescue. We have met with him. We had a number of execs meet with the fire safety officer in Morriston Hospital. We shared with him all of our risk assessments and all of the work that we've done around risk assessing how we manage those patients. He did a visit to the wards, and the feedback from that was that he was, I wouldn't say happy with our plans, because they are risk, they're based on risk assessment, so it's managing the risk, but they have approved the plans that we have put in place on the conditions that are set against them. So whilst it's not ideal, the fire safety officer is content that it doesn't pose an increased fire risk for us for the way we are managing them. That said, we do not want to have patients in that position, and we don't want to have additional patients on the wards if we can help it. So as Richard alludes to, really successful in decanting and de-escalating the emergency department, and that has meant that we have now probably one more patient on each ward than we had previously. We've got to work hard to make sure we can reduce that. That is linked to our clinically optimised work and the pathway of care delays that we've got. So our ambition for 25-26 was to reduce the number of delayed pathways to 100. That was going the right way. So we had set a trajectory for that, and we were sitting nicely on that trajectory. The last week or two, unfortunately, that's gone the wrong way. So we need to refocus on that. As Marie alluded to previously, we had a very in-depth conversation in the Community Noted Persons Board this week. Swansea, to be fair, gave concrete assurance that they're going to work really closely with us to make sure we've got an integrated discharge hub that's fully resourced with the right people in there and work with us to minimise the delays. Neath gave a commitment, but the commitment they've given is what is already in place, which we're going to work with them on. But we're confident with our commitment as well, because some of this sits with us. We've not necessarily got a consistency in that team, and we've got to work hard on that to make sure we're minimising the delays that we've got. As I said earlier, with the move of the Gorsina ward temporarily to Singleton, that does give us an opportunity to manage clinically optimised patients perhaps in a different way, because we have lots of them around the patch, and we could use spare space in Singleton in a different way if we're going to be utilising the ward space. So I think that's something we've got to keep an eye on, Chair. But from a fire safety perspective, we have the sign-off and the approval from the fire safety officer in that respect, but we are maintaining a consistent watch on that to make sure it's managed in the right way.
Anything on strokes there?
Yeah, so I was going to pick up stroke in the performance review, but it's an opportune time. I don't mind which way, Chair. I'll do it now. Yeah. So I took the opportunity in advance, because I notified the committee was going to raise some concerns on there, and noted the concerns that Jean has raised are valid ones. But I just wanted to give an update in the positive performance that we've had in the stroke pathway, particularly since the test have changed through the emergency department. So as a result of it, we've seen a 10% increase in admissions on the stroke unit. We've had a 40% increase in consultant assessments within 14 hours. We've had a 15% increase in physiotherapy assessments within 24 hours. And for the month of August, we increased our discharges from Ward F by 32%. And we've had a 33% increase in transports from Morriston, from the acute stroke ward, into the rehab ward in the Port Talbot Hospital. So we've seen a real improvement in the overall pathway work for stroke. Ahead of this afternoon, I also had a look at, so I get the stroke information on a weekly basis. So I had a look at what happened last week for us. We had 13 presentations of stroke last week. 9 of those had a CT scan within an hour. So the target has now changed to 20 minutes. That is going to be challenging for everybody, but the 1 hour, we're doing really, really well on that. Only 8 came in by WAST. So it's obviously those who self-present that are more of the challenge for us. Out of the 8 that came by ambulance, 2 went to AMU with atypical presentations for stroke, so they weren't picked up as strokes till much later. 5 were admitted to the stroke ward within 4 hours, and that's a huge improvement. That's still not good enough, but it's a big improvement. 2 further patients were admitted within 5 hours, so we had 7, so more than 50% within the 5-hour target. 1 patient went directly to ITU because they were unfortunately really poorly, and 5 were in the range of 8 hours to 19 hours, so they would be our concern for us. The longest one at 19 hours was being treated as a suspected sepsis patient, not stroke, so the stroke was picked up later. Picking up specifically on Jean's point on thrombectomy and thrombolysis, obviously they are time critical, particularly the thrombolysis, so if patients don't present in time, thrombolysis cannot be considered. But out of that, 2 patients were thrombolized out of the 13, so that's 15%, that's way above the Welsh average. And 3 were referred for thrombectomy. So 23% of our patients were referred for thrombectomy. Unfortunately, only 1 was accepted and went to Bristol. So overall, I think we can see the improvements in the pathways, noting there's still some work to do in that one. Pivotal is that getting us those 2 additional posts so that we can get the 24/7 rotated in place. That will help us improve the thrombolysis rates as well. But I think overall, when we look at where we are against the Welsh performance and other health boards, we're doing really well.
Deb, and we know that you're putting a lot of personal leadership into this. So thank you very much for this key working right across the pathway. Thank you. Darren, did you want to come in?
Yeah, just the fire risk assessment is twofold. So there was that very ably covered off sort of operational response to bed management in respect to the fire doors. The other element which will come to quality and safety is the fire risk assessment programme of work that the health and safety team undertake, which are under my leadership. Jean's absolutely correct. We've prioritised patient bedded areas and patient flow areas. There will be other areas of the health board where those risk assessments haven't been undertaken because we're short-staffed. I've got a new head of health and safety to start shortly, and we'll be taking a review of the structure of the team to address that. But we're very much focused on priority and risk at the stage to manage that. But there's more work to do in that area. We need to appraise the board of that.
Thank you, Jean.
Thank you for those updates and good news from Deb.
Sorry, Steve wants to come in as well, Jean. There's
Sorry, before you go,
a lot of interest in that. Jean.
before you go on, Jean, I want to take you back to the prison numbers. Yeah, the staffing in the prison has been an alert from your committee since before we had alerts. So it's disappointing that we still have an issue. So we are, I believe in the prison, we're funded for an inmate population of 250 or so. It's regularly north of 400. And there's no latency at the numbers of nurses that we have there. So it's not like 126% in the acute wards. There's exactly the right number so if somebody goes on leave or is sick or maternity or whatever, there's no cover. We always managed to find a bit of money to fill that gap in previous years, but is it the case that we are not able to do that now?
Well, you stood on quality and safety for a lot longer than I did. You probably have better history than I do.
I can add a little bit to that, and Darren has helped me with this, so we can. So we had taken a look at what is in the resource allocation formula for prison healthcare, and it's a very small amount. So I have written twice to Welsh Government because obviously it's an MOJ matter, but Sarah Murphy is the liaison minister with the MOJ. And I have written twice to ask for consideration, either of an uplift in the NHS allocation formula to reflect this, or that the MOJ actually gives us additional resource. And I've had very nice letters back. Very nice letters back. So, but we continue. There's very, very minimal inclusion in the resource allocation formula, and it goes back into the midst of time and no way reflects the prison population now and the health needs of the same population anywhere.
Well, in answer to Steve's points, if there is that historical evidence, I'd certainly go back through all of the quality and safety minutes to find that. But I think I've taken comfort from the fact that we have been alerted to the fact that it is going to be looked at as part of the wider community. And I will keep an eye on that, and I will come to the November
I mean, they're very specific nurses. You can't take anybody in there. They've got to be accredited with the MOJ. So, you know, it's only those people that are qualified and accredited that can actually work there.
Yeah, I work with prison services. I've also had the experience of being locked in when I was delivering a training session. I know what that feels like. But we will keep an eye on that and come back to you with an update on the November report. Thank you.
Got to move on to perinatal committee.
Yes, please. Before I do, Chair, I do think we should mention that we had the, which we are advising board of, we had the organ donation report, and it was an absolutely excellent report. We commended the quality of that report, the statistical evidence to underpin everything else. The narrative was great. I just think we should make a note of that. And then if we move into perinatal committee report, so board will probably find it unusual that we've brought an in-committee update. However, we felt that it was important, given that we'd had that first committee report, to advise and assure people of what was in there, as well as alert. So the advice was that the publication of the maternity and neonatal independent review, which we all know was reported in July, the subsequent escalation of maternity and neonatal services by Welsh Government from level 3 to level 4 was July 2. Gold Command was replaced by this perinatal committee, and the inaugural meeting has taken place. The project management support is in construct. Unless Leslie has anything further on that she might want to update you. The assurance comes from the maternity workforce is birth rate plus compliant. Personal annual development review and mandatory training is on track. The perinatal service currently has no elements of care that would flag as a negative outlier, and maternity services are fully established within the obstetric unit. The alert that we raised from the report was the single point of access maternity triage is due to launch in March 26. That is entirely dependent on recruitment of newly qualified midwives. The current vacancy of 0.8 whole-time equivalent neonatal consultant from September 25 is also required to maintain British Association of Perinatal Medicine Standards. So we thought it important that we alert board to that latter point. I'll hand over to Leslie to answer any questions that you might have.
I think I will come in as well on the relative priority of the recommendations from the independent review report. Abby.
Yes, thank you for that, Jean. When we received the reviews report, the independent review report, alongside the FLICE work and the maternity sponsored maternity groups family-led review, when we discussed that, we committed to implementing the recommendations. What we recognised is that some of those will take a little bit of time to work through, and Liz is really championing work through the perinatal group and the programme that will support that. And we need to work that in as part of our plan this year, and then our continued plan. Where we can make those changes within the resources we have available to us, that conversation about can we do things differently to free up the capacity we need to deliver against those actions. Some of those things will come at a cost, though, and we're just going to have to work those through and understand them as part of our must-dos, as part of the plan for the remainder of the year. It's really important that we give confidence to the population that we serve and the commitment we've given as a board to do that, and we will do that. And we can say a bit more about that when we come to the perinatal committee report. Jean, thank you.
Thank you. Thank you, Jean. And again, thanks to you and the committee for the diligence with which you're undertaking your AAA reviews and all the work programme of the committee as well. We do have Sharon Miller, who's come to present on community pharmacy. So can we just juxtapose 4.6 and 4.7?
So we'll do that, Jen. That'd be really helpful. Thank you.
Yeah. Is it on to ask Sharon to come in? Thank you.
Was it, sorry?
Do you want to count, shall we crack on with 4, 5 then, what she's, so Darren, is that you to start?
Yes, but I'm going to be very brief because we've agreed to give 7 parts.
Yeah.
Chair.
While we punch. Right, okay, please start then.
So I'm going to be handing to Bill to start the population health section, followed by Deb, Richard, Deb again as the D, and then Tina picking up the 5 component elements. We've choreographed this. And I'll hand to Jill to start.
Please start.
So, to say that, we have our standard slide set with the standard measures there, have some updates on the immunisation statistics. So the percentage of children up to date with scheduled vaccinations at the age of 5, we are 90.3, but the Wales average is 87.7%. On the human papillomavirus vaccination by the age of 15, we have Swansea Bay is 85.9, so we've gone up slightly. The Wales average is 74.1. The percentage uptake of influenza and COVID vaccines obviously will be dependent on this season, and you'll have seen that your screensaver has changed to the boost screensaver. The smoking cessation targets of 5%. We know that our inpatients are reaching 3.45%. We don't have the CO validated quits from the community data that's rated with New South Wales. Colonoscopy data will be from the divisions. Don't have that at this stage, but the percentage of babies entering newborn hearing screening within 4 weeks has always been over 98%. Likewise, the percentage of eligible newborn babies with a conclusive blood spot screening result, that is over 90%. So the charts show the old data, but just a little bit of an update on these. This is positive.
I should have added, this is in the reading room for colleagues who may be looking for this in a different file.
Okay, so over to me. A lot of obviously the performance stuff that I normally talk about, we've picked up a lot. So I will go through a brief in a second and need to come back to and have the questions on that. So slide 11 is the first slide on that stroke. I think we've covered off, so I won't touch on stroke anymore. Planned care, almost will be used to the really positive performance that we've got in the planned care world. I do need to alert the board that at the moment we've had 2 patients that were subject to a digital error this month in our system through DHW. We have fed it through to them. It's a technical glitch and they've popped up when they weren't expected to. One we've resolved, the other one we are trying to fit in on Tuesday to make sure we do not have a 1 or 4 week breach, but it's not through our offices, unfortunately, when we were doing our best in that respect. All that work.
Chevron left. 16.
I'll just switch it off.
Chevron.
But that work continues to go well. We're doing the additional work through the Cabinet Secretary's office as well. Diagnostic therapies, you will see that the performance has deteriorated there. It is purely down to the endoscopy work programme. We have now got agreement for the mobile unit to come onto site. It'll be on site next week. The procurement took longer than we anticipated, unfortunately, so it was a little bit delayed. I was initially informed it would take us 2 weeks to commission that unit, which means it would be on site and ready in October. Unfortunately, it's not 28 days because we have to do water testing. So it will go live at the beginning of November. However, I have been assured that that still allows us time to deliver the plan that we've set out. We do need to be mindful that conversions to endoscopy are going up because of the additional outpatient work we are doing. The funding for the mobile unit was to clear the backlog prior to that additional work being undertaken. So it will not clear the 8-week target as it stands. We are waiting for confirmation from Welsh Government that they will fund the rest of the backlog removal that's accumulated as a result of the outpatient work, which we think is coming through, but we're waiting on that one. But still really positive in the planned care space. If we go on to unscheduled care, we touched on that. Performance continues to be positive. Our ambulance handovers by way of the 45-minute targets is, I think we're 3rd at the moment. It's worth noting the calculation that they're using doesn't include all of our ambulances. They're only including those currently that convey to ED, whereas we've got pathways that go directly to the acute medical unit. So I'm working with JCC and WAST at the moment to make sure they're counting all of our pathways, which will hopefully bump us up a little bit. And that's positive. The formal measurement of that comes into place on the 1st of October, so that will then become a formal measure for us. All the other measures are continuing to go in the right way. We want to see some further improvement on the 12-hour waits in the emergency department, and that will come, I'm sure, but still largely positive, and we're getting the accolades for the improvement work we are doing there, so that's really good. Pathway of care delays, I think we've touched on them, Chair, so I won't go into any more detail on the pathway of care delays. Ambulance handovers, when we presented the data on ambulance handovers and the unscheduled care world in particular, we put down the increase in ambulance demand as a red indicator for us. We've revised that now and put it down as a green, because actually we've got 9% more patients coming to us in an ambulance. That's a positive from a patient perspective. It means that the ambulances are being released and they're going out into the community and bringing them back in. So we've reviewed that and changed our tact on it and seen it as a positive for us. But we are seeing an increase in demand coming through that way as well. Stroke, we've covered, I think, in depth. Planned care, we covered diagnostics. I'll move on to cancer then quickly, Chair, because that's the one that we've got a lot more work to do. Craig Wilson has been supporting me in planned care in cancer performance with Raj from Richard's office. Hannah Parsons started with us at the end of August as the Assistant Director for Planned Care and Cancer. Hannah will be picking up cancer performance from the 1st of October. I've already asked Hannah to put some meetings in the diary for her, myself and all of the tumour site leads individually to go through individual recovery plans. Initially to review the backlogs that are growing, unfortunately, at the moment, and to put into plans some recovery in some of the main tumour sites. We've also spoken to NHS Performance and Improvement, and they're going to do some focus work with us in urology. Urology is a particular issue across Wales for cancer performance. There's lots of different modalities in urology, so it's not one condition. Prostatectomy is generally the one that we breaches, and our volumes, if we look at our total breaches, urology is generally the one with the highest number. So that's why we're going to do a focused piece of work in there. So I anticipate some improvement as we go into November and December, Chair, and I hope that will play out in the figures. So I'll stop there and take any questions. Nicola.
2 questions from me, if that's okay. Mental health, the 43.6 patients waiting less than 26 weeks for therapy. There's obviously still a lot of patients that are waiting over that 26 weeks. What are we doing to support those patients in the meantime? And a similar thing for CAMS. I think the numbers are really low in the 28 turnaround. So just wondering what we're doing to support those patients.
So we are focusing on the Part 1A, 1Bs in the first instance to get those numbers where they need to be. So we know what we've got to do with those patients. The 26 weeks for psychological therapy, we are reviewing that with the CMRTs. Couldn't get my numbers right, my letters right there, to see how we can work with those therapies. It is a problem across Wales, so it's not particular for Swansea. We know the psychological therapy element is complicated and time consuming. We have looked at group therapy for these patients, but a lot of patients don't want to engage in the group therapy work. So what else can we do differently to address those? So I don't have the answer for you today, Nicola, but if you like, I can get you a brief on specifically what we're going to be looking to do in that space. And then my resident expert's going to come in and help me.
No, I think there are a number of interventions. The problem is lack of psychological therapists, and to put an intervention in earlier, it increases the waiting list. There is things like Silverlight, there's digital applications that we would send people to. And again, there are some groups, but yeah, not a lot of people do come to them. So I think what we said, but it is an all Wales problem. There's a lack of the staffing resource and also a huge increase since post-COVID in people coming forward for psychological therapy. So yeah.
I'll update you on that, if that's okay.
Thank you.
Drop me an email and I'll
Yeah.
remember.
I don't think there are any
No,
more.
okay, I think I'm handing over to Richard.
So I've got, if you're following on the pack, colleagues, I'm on slide 19, which is the IP&C slide. I'll add something on C. difficile at the end. I mean, the graphs show they're not immediately apparent on this view. We did have a spike of E. coli infections back in July, and curiously they were predominantly in primary care rather than hospital-based. The team there looking at the cause of that, they're nearly all associated with urinary catheters. And it's highly likely that the timing of that spike, which coincided with the heat wave, was related to patients with urinary catheters, dehydration, and an increased incidence of E. coli bloodstream infection. The Klebsiella species Bacteremia is on the bottom right. They are higher than they should be. The majority of those patients have biliary and gallbladder disease and are on the waiting list for gallbladder extraction. And we know that in terms of the upper GI pathway, we do have delays in that pathway. That means that they can be more of a challenge. And the only thing to add in terms of over and above what I mentioned earlier was around the C. difficile. Which to mention, when the chief medical officer visited a few weeks ago in the ED, one of the things that's unusual about Swansea Bay area is that our residents have a very high background rate of C. difficile carriage. In other words, they're not symptomatic, they don't have infection, but they carry the C. difficile back, and that's not very well understood. So that had been noted by the new chief medical officer, and so started exploring with her how we might look at that in more detail to understand the drivers behind that, and to see whether there's something that we can do that's unique to Swansea Bay, either in terms of research or particularly from a public health angle, to see whether there is something unusual about our population that makes them at higher and puts them at higher risk. And then let me pause there on IPSC and I'll come on to mortality.
How that's picked up. So that it is quite an interesting statistic, isn't it? So how is that picked up?
So when we test stool sample, we test to see if they've got C. difficile, but we also test to see if they've got the C. difficile toxin. So if the sample is toxin positive, indicates infection, whereas one that's the PCR, the genetic test for C. difficile, says C. difficile in the bowel, toxin negative, not got symptoms, means they're a carrier. And one of the how that manifests with us is that, for example, if we had 5 cases of C. difficile in Morriston at any one time, if we take the samples and do the genetics, it's often the case, but not always, that when you do the genetics, they're all different genetic types. So they're not transmission between individuals, they're all different, they all come from our population, all different backgrounds. When we get an outbreak, we'll find the same genetic link. It's the group of patients who have the same bug with the same genetics. But what's unusual about it is we do quite often see we'll have multiple patients who still test positive for PCR C. difficile, but not in the same genetic type.
And is that unique to us in the UK, or do we not understand that statistic?
We don't really understand this. I don't think it's unique to us. There'll be other places with high background rates. It'll almost certainly be linked to things we talked about earlier: deprivation, contact with healthcare, frailer, older populations, and history of antibiotic use. We know that in some of our practices in those areas, high deprivation, there's a higher incidence of antibiotic use. So they probably all, the answer is probably clustering around the same thing, but it isn't fully explained, which is why I wanted to explore the CML as well as you to just understand in a bit more detail.
Did you want to add?
Not on that, but looking at the respiratory type viruses, you can notice in the population stats there's been a real drop of staff in direct patient contact having like flu vaccines since 2021. There's been, you can see quite a significant dip. What is the policy with staff having vaccinations against flu and COVID?
So we strongly recommend, there's no mandating for vaccination staff. Jill and I and maybe Chris have recently sent a letter to all staff, so we've countersigned the same letter, so all of our staff get the same letter, and that really does the same thing. But also puts it in the context of a professional responsibility. So while it's not mandated and it's recommended, actually we've in that letter gone a bit further on that, and saying actually it's a clinical responsibility to do that and protect staff, protect patients, but also for people as well to protect their families. They're coming into work and putting themselves in an environment where they're more likely to acquire respiratory infections, and they may well go home to a child or a vulnerable relative who's older, who is then at more risk of getting the infection and of getting a poor outcome from that infection. So it's recommended, but we've added a layer on top of that, of it being capturing it in terms of professional obligation that we feel is a professional obligation to do it.
Richard, do you want to add in terms of our communications around this?
Yes, and I'm sure Jill
Bill?
can as well, some of the practical ways that we made access to vaccinations easier, but it's subject to a big campaign right now, titled For Me, For Us, For Them, around, you know, the importance of being vaccinated. This is one of the highest profile things we're doing right now, as well as the letter that Richard referred to. It's on the front page of the internet as the lead story in the midweek message. We're doing a whole host of things around it, but it's not just the communications, it's around the accessibility as well. I think Jill might say something about that.
Had a fantastic response to our appeal for peer vaccinators. So many people will be being vaccinated by their colleagues. On COVID though, specifically, this year, occupational COVID vaccination wasn't recommended by the Joint Committee on Vaccination and IMS for the UK. So in Wales, there was a little bit of a theory because it was left open to health boards. So we've worked, Abby has taken recommendations from us that we provide by the JCVI regulations, and all of the chief execs have agreed to that in Wales, with the in Wales position that we are abiding by JCVI recommendation.
Thank you, Richard.
Sorry, and I was going to do mortality, wasn't I? So the mortality stats are on slide 31. If you're following along. Slide 31 shows the crude mortality rate for Health Group, which is steady and is monitored closely. One particularly wanted board members to draw to your attention is the graph on the bottom, which reflects the deaths in ED. So you'll recall that as part of the GIRF visit, and with the Ministerial Advisory Group several months ago, there was concern that our apparent ED mortality was higher than it should be, and the question of whether that's the case, that there were, what was the cause of that? Our feeling at the time was that that was related to patients coming into ED and we weren't able to move on to an appropriate environment when their death was expected. So for end of life care, and actually what you can see there is it's pretty dramatic since June, and that change in the flow around scheduled care. But we've seen a marked reduction in deaths in ED, which is great. And what that of course means is that it's a better experience for patients and their families, and that we're able to move people to a more private, to a hospital bed rather than being in the ED with lots of weight. That's a positive message. And, sorry, I'm going to Leslie.
Thank you. So I'm covering slides 25 to 30. So in relation to patient experience, acknowledging the Civica system will tell us a lot of data. However, we do listen to people, patients and staff through our assurance visits and the independent members visiting program. So that's been key to triangulating our patient experience. What the data does tell us is that we have made improvements in our scheduled care services, but acknowledging there's more to do within our AMU footprint, particularly in respect to patient experience. For complaints, just to note, the complaints, concerns and incidents team came across to the Executive Nurse Director's portfolio in July. I'm line manager of that team, and I'm personally shadowing the corporate team and some of the service group teams, and we've got a focused piece of work in terms of addressing overdue concerns. The introduction of the new listening to people guidelines would prepare for that. We've got 2 engagement events planned in October that will reflect on the findings from the maternity review in respect of compassion concerns responses, and working with teams in terms of early listening and acting to concerns that come into the organisation. The serious incident position, just to note, there's been no new NEBRA events, and theatre improvements program, just to highlight that group overseeing nationally reported incident and ensuring there's oversight and learning integrated into practice as soon as possible. Falls, we're doing, so the positive position, we're doing really well. The inpatient incidents remain well below the national average. Our rate is 4.23, sorry, our rate is 4.23 and the national is 6.6 falls per 1,000 occupied bed days. We're currently doing a piece of improvement work with care homes to reduce conveyance and improve experience and outcomes. Pressure damage, there has been a slight increase in rates, 4% compared to last year. However, reduction in harm in NEAF, target Singleton Service Group and primary care, has been a 50% reduction compared to last year, and we're still aiming for a 10% reduction. And those are the key highlights of those slides.
Comments, questions for Leslie?
Jean, I'd just like to comment on the difference that this type of reporting is making. Because I think it's been a major step forward. We now understand what the underlying causes are, what we're doing about it and what it means for us. So I welcome the change in the report.
Be gratefully received. Jean.
I'm handing to Dee now for the digital section, please.
Thank you. Yeah, so from a digital perspective, a lot of the KPIs are quite qualitative, I would say, at the moment, and they reflect the key objectives and commitments we've made through the IMTP for this year. So there's currently work underway about how we now put them into a more smarter process so that it aligns with some of the KPIs from a planned care, cancer, UEC, and importantly, mental health transformation perspective. And they will focus on both digital adoption and inclusion for both our patients and our members of staff. I think it's next.
Yes, thank you. Just two performance issues to highlight from a workforce perspective. The first one is an alert from the Workforce and OD Committee, which is around the PADR appraisal rates. We're not seeing any improvement despite some additional support we've put in place through the HR business partners. So we'll continue to liaise with all managers with the outstanding appraisals to get dates in the diary for those meetings to take place in the next couple of months. So that work continues, but again, we just need to make sure that we're all of us are taking responsibility for our areas and then making that improvement. And the second aspect is around the sickness absence rate, which we've got a paper later on, Chair. So I was going to pick up then.
Thank you, Tina. That'd be really helpful. We'll come to that under our people section.
And the finance section is there for completeness to show the integration, Chair, but obviously we've had a very thorough discussion on that.
Okay, thank you. So can we welcome the way in which the integrated performance report is developing? As Jean says, really helpful, helps us get underneath the indicators. How does something happen? What are we doing about it? With what intended effect? So we can acknowledge it and take assurance from the discussion that we had. Thank you.
And there are new metrics to come, which we're shaping under the leadership to give it to Matt Neo.
So we look forward to those as well. So Sharon, lovely to have you with us, and Chris or not, welcome back. So members have read the paper, so you need to take us through it in detail. If there's anything you want to highlight, and then be available to answer any questions.
Thank you. Thank you, Chair. So this paper is another broad overview of community pharmaceutical services in the same vein as you had for medical and dental. Just some very quick basics. So 90 community pharmacies compare well to the provision across Wales. And those community pharmacies dispensed last year 10.8 million items. The strategic direction is to move beyond that dispensing and in addition to provide an ever increasing range of clinical services to our population. A few things I'd like to highlight quickly. So the Clinical Community Pharmacy Service, which is CCPS, is meant that you can walk into any pharmacy in Wales and receive the same services. Currently, we have 5 services in there, so that's common ailments, emergency hormonal contraception, emergency medicine supplies, very recently sore throat test and treat from July, and then from next week, actually, urinary tract infection. So there's been a huge development to encourage and support our community pharmacies to be able to provide those services. And I'm really pleased to advise board that we have 100% uptake in Swansea Lane.
Can I just ask on that, Sharon, you no longer have to be an independent prescriber then for those funding. You or do you? No.
So that's all our pharmacies will provide common aid. 2 more things then quickly. The pharmaceutical needs assessment. So about 4 years ago, a lot of work was done on an in-depth basis to analyse and assess every pharmaceutical service provided to the population and whether it was sufficient. We're about to embark on another 12 months of work to do that detailed analysis now by service, by pharmacy for all of our geographical areas. And we'll be bringing back to board next year a revised pharmaceutical needs assessment in line with the statutory bodies to do every 5 years. And board will then, determine the recommendations as to whether we still feel that we have adequate community pharmacy services for our population. Finally, then, from me, independent prescribing, which you mentioned. So that's a big development in community pharmacy. We have 35 community pharmacies who deliver that service currently. But depending on individual universities, community pharmacists will start coming out of training with that qualification towards the back end of this year and into next year in Swansea and Cardiff. So we have had a 100% increase from this year to last, but we'd expect that to go up further in line with the Welsh Government aim to have every community pharmacy with an independent prescriber by 2030. I leave it there, Chair.
That's good. That's really good. Thank you, Sharon. Deb, do you want to add anything?
No, nothing to add from my perspective, Chair. Thank you.
Some really good news. Anne-Louise.
Thank you. Thanks, Sharon. It is really good news and it was a really comprehensive report, so thank you. What I wonder is what kind of promulgation of the services is there in multiple different languages to make sure that those people that we mention quite often in board meetings, those hard to reach groups, actually recognise that they do have some support in their local area?
Yes, this is an area that we are looking at in terms of our health inclusion work, which we're starting in primary care, just to make sure that we're looking at equity. Our community pharmacies will have obligations and they do have to complete a governance framework so that we actually check on that. But I think it's an area that we need to look at and develop further as we do that health inclusion work.
Within what time frame could the board have an outcome from that work then, Sharon? So
we're due to start up our working group in October. So we would expect to be able to bring something back to board on health inclusion within 3 months.
Andrews, do you come back?
What is there in place already that's in languages other than English or Welsh that will notify local populations who maybe are not conversant in either language?
At the moment, we don't have the detail of the provision because they're independent contractors. We will have a general requirement on them to take account of equality and diversity, but we wouldn't hold the detail of exactly which languages they provide their promotional material in. It's certainly something we could look at.
It must be known that the sort of the population that you have around a particular pharmacy, what languages are spoken. It seems a gap to me.
To take that as an action, Annalise. I think some pharmacies do use a translation line service, but we will,
Yeah, certainly our pharmacies will have access to language line in terms of interpretation. But I think you meant
And I think particularly bearing in mind what this report sets out that pharmacies can provide, that it's an ideal opportunity to take people away from the secondary care or even GPs into the pharmacies.
Yeah, I would just say on that bit, Chair, obviously pharmacies are businesses, so I would assume if they're based in a population with a diverse demography, it's in their best interest to make sure we're doing that. But we can certainly do a review of what that looks like in some of our more diverse communities.
Nicola, you wanted to come in.
Thank you, Chair. Thank you, Sharon. It's a fantastic report. My question is, out of the 90 pharmacies that we have, how many are open late in the evenings, weekends, etc.?
Something for
Oh,
I'm no active pharmacies usually. So just to say that every pharmacy has to open 40 core hours a week. So therefore we got 3,600 hours. But we also have supplementary hours. So there's 569 supplementary hours per week, which is where the pharmacy is choosing as a business to open beyond their core requirements. So we have got 22 community pharmacies across Swansea throughout the day and access from over until 10:30 at night. And then in East Port Talbot,
And that's on a Saturday. And on a Sunday, we've got 8 community pharmacies, the latest closing at 6 p.m. And then on Sundays, we've got 3 community pharmacies in Neath Talbot with the latest closing at 10 p.m. So we have got good coverage of supplementary hours, but we do also then commission a rota services for areas that are not so well served as well.
May I ask a question on that out of hours, because I think it's provided for the service something like 300,000 a year it's costing. Do they actually pro rata the cost of that out of hours service? Or is it's a charge for everybody, whatever time of day, whatever time of night? How do they actually work that? Is it seen as an extracurricular, or is it seen as a standard service provision? And if so, is the allocation of funding appropriate to that?
So the rota services, we commission from 7 community pharmacies rota services because we have got that supplementary service provision. The rates are set nationally. So the rates go before 7 p.m. and after 7 p.m. for weekdays, Saturdays, Sundays, bank holidays and special bank holidays. And the rates are set on a national basis, but it's per hour. So we did a review of out of hours services last year because Sainsbury's and the Arena pharmacy had closed, and we were getting some correspondence regarding that, and we did put additional rota services then into Talbot. If the pharmacies who are providing the service as supplementary were to withdraw, they don't need our permission, they only need to give 90 days notice. That would be a big financial impact on us.
So would that be part of the conversation that you have in the upcoming meetings with primary care as well?
Yes, in terms of health inclusion, but also when we do the pharmaceutical needs assessment, we would have to take a view whether our out of hours service provision is satisfactory for the population.
Thank you. Helpful, Jean. Thank you.
Steve?
Yeah. Thanks for the report, Sharon. We had this report in Population Health Committee 2 weeks ago and took a lot of assurance from that. There's very good coverage across the piece. But one of the areas that you look at closely is sustainability of these businesses. And it is quite tough at the moment with shortage of pharmacists and also drugs sometimes. But there's one in particular, isn't there, in Morriston, which is in the news and under pressure, called Jutes. It's part of a national chain with 150 pharmacists. But we're managing that. I mean, we're managing the situation such that people that use that pharmacy can get their supplies elsewhere. Yeah.
We are indeed, and so it's in Jacobs, I call it, it's in Morriston, and it's currently closed, and we're dealing with it through our normal contractual processes, and also we'll be reviewing that situation. We are lucky, as it were, that we have, as you say, neighbouring pharmacies, so we're not having sort of patient complaints around it, but we are concerned about that situation in common with many other health boards in Wales.
Yeah. Thank you.
Any other comments or plans for Sharon? Well, Sharon, thank you again. Every time you come, you demonstrate what a subject matter expert you are across all the different domains of primary care. And lovely to see you again. And we hope that you'll come back and give us the outcome of the work into health inclusion. Thank you. And we can acknowledge and take assurance from the report and presentation. Thank you. Yeah. So Deb, shall we come to the winter plan?
Certainly, Chair. So I'll be brief on this one. So planning together for winter, the plan hasn't been submitted, so it needed to go in by the 12th of September. So it's approved by yourself and Steve in Swansea Local Authority. So what it is, it further enhances our winter planning that's been evolving over the last few years. And it's a regional approach to the plan for winter by the RPB. This one is in the format of a self-assessment in its current guise rather than the full plan. The full plan will need to go in, I think, by the end of October. And it outlines the arrangements between ourselves and partner organisations to maximise organisational and regional resources to meet Welsh Government priorities ahead of winter. So our template illustrates the opportunities and the plans the region has to deliver actions via core funding and existing additional funding and grants that we've received. We need to note that Welsh Government at the moment is saying there is no additional funding going to be allocated into the winter planning for 25-26. That may change, but at the moment, that's what it looks like. So the report is presented to the board from Assurance, just to pick up on a couple of issues. The original ask for the plan was to deliver updates for the 3-week period from the 22nd of December to the 13th of January. That has now been extended from the 1st of December to the 31st of January. It doesn't really make any difference to us, Chair. Our plan already covers that period, but it's just an extended period that we're going to be looking at. Our plan mirrors that we implemented in 24-25 that I would say worked really well for us. Modelling has been undertaken by Welsh Government colleagues and local business intelligence to look at worst case and best case scenarios. The Welsh Government modelling hasn't been published yet. Once it is, we will overlay that with our own modelling and come up with where we think the best fit looks like for winter. Obviously, we never really know what the winter months are going to bring us in terms of norovirus, RSV, and more importantly, weather. So that always plays an important part for us. But our plans are evolving in such a way that we will cover off all those areas. Just looking at the detail, there's a page 5 details the priorities of our plan, and they're the ones we would expect to see in terms of where we are for a winter plan. And page 6 takes us through the monitoring and reporting arrangements and the risks that we're perceiving them at the moment. Just looking at the financial implications, because obviously that's a big consideration for us in terms of where we are. There's no additional financial implications as a result of this plan. They are services that are already in existence for ourselves and local authorities, but we need to be mindful of the risks posed with the current financial climate, and should any resources change, that will have an impact. Importantly, probably from ourselves and local authority perspective, if we're looking at our CAC costs, for example, and things shift, then local authority stance is, well, if we have to pay more for X, then we have to withdraw money from Y. So it's a very finely balanced plan at the moment, and we've really got to maintain that partnership working to make sure we can maintain what we need to do. And the self-assessment, most of ours, I think we're quite critical when we do self-assessments as an RPB. We certainly don't overscore from a generosity perspective, so it's the worst case scenario with us. We only have a couple of schemes that are flagging red for us, and they are both around the monitoring of the 0.5% of vulnerable patients in the community, particularly with COPD. And that's purely because there are contracts needed to be put in place for that, and we simply don't have the additional money to do that. So what we're doing is working in conjunction with Sharon and primary care colleagues as to what primary care should be doing already to monitor these patients, and then we can plug the gaps within existing core resources. All the others are amber or green for us. And most of the ambers are around 7-day facilitation of some of the services, where we've got most of them over 5. So I'm quite confident where we are with the plan ahead of submission for winter this year, Chair. It mirrors last year's and improves on that and the year before. So I think we will be in a relatively good place. Fingers crossed.
Thank you, Deborah. Don't minute that last sentence. Rita, do you want to add anything?
No, just that it has been a really comprehensive piece of work done in full partnership with our RPB partners and with really good engagement across everywhere. I was just going to reference the meeting on Monday with the Cabinet Secretary, which winter plan is being discussed as part of that engagement. That's going to emphasise. Thank you. Chris, then Jean.
Another thing that we are picking up alongside the winter planning is our mortuary plan for Christmas, because we do have, increased work in that area, and we're linking it in with the winter planning process and the work with the medical examiner as well.
Yeah. Yes. Yeah. What a nice secretary.
I know. Yeah,
Needed.
It we need. It's bank holidays over Christmas, funerals, all of that thing. So we do have pressures in that area. Yeah.
Thank you, Chris.
Really good to read the narrative behind all of your planning. I guess my question is, how frequently do you pulse review that self-assessment report? Because it's one thing doing it up front.
Yeah.
But it needs a pulse review continuously, doesn't it?
Yeah, and we do that on a regular basis as we go into winter now, Jean. So this is the first submission of it. We will be doing a more detailed review of the actions that we put into place last year. The self-assessment is quite high level. There's not the number of, certainly not the number of actions that we put into place last year. Our own internal plan through the RPB will be far more detailed than that, and we will be revisiting that on a monthly basis as we go into the period.
And do we as a matter of course have a plan B if plan A doesn't work?
We don't. So the plan covers all the eventualities that we can think of as it stands, and we will need to improvise as we go forward as things change. It covers off the eventualities and the modelling as we've got you. So all the considerations that we face through winter are included in those plans. So they should be really broad in terms of what it covers off. Other than obviously business continuity incidents that we come across, we manage those as we go through.
Yeah, so there will always be business continuity plans in place. Yeah.
If we needed a plan B, it would mean that my plan A is not good enough. So it needs to be
Can I just
pretty
say
broad.
we use the word plan, it's actually many individual component parts. So it's really a program of lots of specific pieces of work. So and there will be lines that work better than others, and it's just, as Deb says, keeping a constant review and adjusting where.
I could have just noted, Chair, thanks to Marie's team and for Kelly Gillins in the RPB for pulling it all together. Still a lot of hard work in the background that they've done for us.
Matt, you want to come in?
Yeah, just a quick question. You mentioned previous years we got funding from Welsh Government. We're not being made clear, we're not this year.
Yeah.
What level of funding did we have?
We didn't get a lot last year, Pat, to be honest. We had slippage in, so we've had the First Faster funding coming through, and we had some slippage in that we were permitted to be allowed to use for the winter plan, because there was around appointments of additional staff, etc., that we didn't need. Nothing has been forthcoming at all this year, other than the grants that we've already had through some normal core businesses.
Is there earmarked funding in RPB?
There's lots of different grants through the RPB space that we work through.
197.
Oh, grant, not
Lots and lots of different bits of money that we apportion all over the place. It's very big bits.
The community services review obviously is going to be critical. When does that complete?
So it's going to be a 3-month review. So Mel Rogers has been with us now just for a month. She's on the verge of doing the terms of reference for us on her initial findings. What we didn't want to do is produce too narrow a scope for her without her coming in and having a quick look at what she thinks needs to be looking at. So she's working with Emily, who was on the screen earlier on, to draft those. That will then be a 2-month review to go forward. So we'll have the output of that, I would think, end of November to see what that looks like. But that's going to be a longer term, obviously, plan, because most of it is around workforce.
So on that, we've done a kind of a complete open book reveal of all of the services and investments that we make across the whole of primary care and community services with the RPB teams to say, let's just be totally transparent. Let's look at what we've got, where we're spending it. Lots of that will be on very specific health-based and health-delivered services. But what we want to do is say, look, have a look. Let's look at where there are opportunities to be radical. And that's going to form the next phase, if you like. So the community services review is being driven from a health board perspective. We're now looking at the wider, and this again will feed into the integrated community care system planning that the Cabinet Secretary is so interested in getting underneath.
Thank you. So again, then please convey our thanks to everybody who's involved in putting all these things together. So we can take assurance on the approach, because it's done through ourselves and our partners at RPB level with a lot of engagement. And we can take assurance that you continue to populate the self-assessment template. And as you said, there are robust operational delivery plans that sit underneath this that you review regularly. So we've got the process and proposed governance and monitoring in place. We can take assurance on that. So thank you very much for that. So Chris, we come to you now then on regional pathology and the possibility of a single regional solution for South across South Wales.
Yeah, thank you, Jan. Again, I'll assume the paper's been read, and I'll just briefly go through where we've been since we last brought discussion to the board in March. In March, you will remember that we, first of all, I want to thank Steve, who's been supporting us with this, and the Vice Chair from Hywel Dda as well, and Neil Miles, the Programme Director, he's been working through this. In March, you remember, we came to the board, and Welsh Government had, through the Capital Prioritisation Programme, said that the the large regional, the whole of pathology service at 135 million was unaffordable. And we were challenged or asked by the board to go away and work through what we needed to do to develop with a specific focus on cellular pathology, which was our most critical and most suitable for a hub solution, and to look at different opportunities around that and to bring a preferred option back to this board. And since then, the Ministerial Advisory Group have also supported that and supported our the priority around cellular pathology in particular. We have worked with Lifecycle Consulting, who are a specialist pathology consultant across the UK to help us look at this. And we looked at 5 options around where we how we develop the service, and that's the usual from do nothing, do minimum, look at Hywel Dda in its own, and then a complete new laboratory hub for Swansea Bay and Hywel Dda. We have come to the conclusion that option 5 is the preferred option, which is a new regional laboratory that's accepted across the region and by Welsh Government. It's in line with regional services and the models across the UK on bigger footprints. We've looked at site options, and we have come down to an option between 2 different sites, which are units that with shared services, and we are going through an appraisal on those sites now to see which is the most suitable. Welsh Government have asked us to develop a single case business case around those 2 sites, finding the preferred option, and that's what we are working through at the moment. So I say we were looking at 3 sites. The first one, Davern Industrial Park, was too small and would only have fitted in a single service and would have been an interim solution, so that was rejected. And we are looking at 2 sites now. We are working through the cost of those and an indicative programme. And yeah, so today the recommendation to the board is that we look at all 5 options. Sorry. Yes, my God. And we come to the conclusion to recommend option 5 to us of a single regional laboratory, developing a single case business case with us as in Hywel Dda with speed because of the issues, and also to have a look at how we may support each other's services and develop to a regional service in the time that it takes to progress. So I think, I don't know if Steve wants to say anything else as well.
Sure. And thank you for your thanks, Chris, but actually it's Chris and Neil and Darren that have done all the work on getting this.
I didn't thank him, sorry.
And the equivalent teams in Hywel Dda. So it's important to note that Hywel Dda are sitting in their boardroom today, and they've got exactly the same paper coming to them and exactly the same recommendations. So we're doing this very much in combination. I think it's also important to say that this would be a flagship project for the new RJC. If we can pull this off, it shows that we can make the regional joint committee. We are making the regional joint committee really work. We've been told in no uncertain terms that well, any funding from Welsh Government for new pathology operations will only come if we regionalise. So there won't be any individual funding for us or for Hywel Dda, who are in a worse state than we are in terms of the facilities. And they've given a very strong indication that money will be available, as Chris just outlined. We're going through site selection. There are 2 sites. We'll leave that to the experts as to which site is recommended. The business case we need to develop at pace. So I think this is quite an easy decision to reach. We are providing substandard pathology services at the moment in both health boards. This will help us get that right. It will, in particular, it will attract more experts to come to this region to work. So recruitment has been impossible in Hywel Dda and difficult in Swansea Bay, but this on the table would make that situation change. And you know, I can't see any reason why anybody would object to this proposal. So And one other thing, I understand that the teams and once this decision is made here and the same decision is made in Hywel Dda to approve this approach, the teams will be brought together, will be spoken to in individual meetings and then later together. But when we've done our rounds of the places, we've got a very strong impression that both sets of staff are very keen for this amalgamation to happen. And they're really waiting for a decision to come from the two boardrooms. So I commend this recommendation.
Sorry, can I just come back as well? This is in line with the national recommendation for 3 regional sites within Wales. We have done a market exploration. Our population is slightly small for the market to be immediately looking at this, but we will continue to look at the market to see if there are partnership opportunities and across South Wales with that. And in terms of the staff, we did meet with them earlier this week. And so we've had a discussion and we are meeting with them again tomorrow after the boards as well to feedback on this. After the meeting this week, there were very few questions raised and we've had nothing back this week to suggest, because they have been with us on this journey. It's just gone quiet since the boards in March. Yeah.
Rena, please come in. Just a point in terms of the pace of this. I know how urgent you mentioned that they've got really poor facilities, particularly in Hywel Dda. Are we going to have any particular risks over the next 2 years that we need to be aware of whilst we're waiting for this solution to come to fruition? Because it says 18 to 24 months. But my feeling is it may take longer than that. It often does overrun, doesn't it? But I just wondered, is there, I mean, and in the sense, if there are risks, what are we going to do to mitigate them?
I and others are working on a plan on how we progress with this. My recommendation is we immediately start looking at how we run the service regionally and look at our joint resources and how we can work together to support that. In terms of how we start to look at our staffing in terms of as a joint team. So I think a lot of that we will move through. There may be some opportunities to move some work from one site to other, even though all our sites are restricted. In some areas, we have specialist services in Swansea, which we may be able to move or support work with. So I think we are going to be working through that. There will need to be a plan from now as part of this agreement to use the organisational delivery network to start developing us as a regional service. So we think regionally, look at all our resources and assets. There may need to be in Hywel Dda some moves and some space allocation as well, which they're looking at, but they are interim, but they would be interim arrangements, but that would be in the context of us working together.
Is that the issue around pressure on Glangwili?
Yes. The Glangwili estate is worse than ours. Isn't a good estate, but Glangwili is very, very small site and poor. So it is what opportunities we've got, but there's a whole workforce and finance and a commissioning model for us to work through this. We need to start that plan in parallel with the business case.
Any other comments, questions?
No, just to say, really good progress. I think when we were sat in the regional committee, we were anxious about could we get recommendations and options really clear for September. So well done to everyone who has done that and achieved that. And considering where we were and the fragility, as you say, Steve, this is a real signal that we can do joint therapy. It's difficult across organisational boundaries, but this will be so much better for our patients and actually for our staff. And it's a key example where we can deliver a sustainable model and also have a service that's amenable to further join up across South Wales, because we can anticipate that will be a further step and iteration at some point. But us having a plan with Hywel Dda is fantastic, and commitment for us to work with Welsh Government to really push this forward quickly. Your point, Rita, about timeframes, we know, and actually Welsh Government being really supportive.
So pathology is a multidisciplinary service. This is the first of those disciplines and it's the most acute, and it is the one that most lends itself to a regional hub. This is the first step on a journey with pathology as well across the South West region, but also across South Wales, which is.
Has Welsh Government given a time frame for submission of the business case?
They've asked us as soon as we possibly can get that. And so the capital teams are working hard on the two locations to see if they are both options, and there will be a commercial discussion then. If we came to a single decision, Welsh Government are keen to support us to secure that location. And so they are wanting a business case as is reasonably possible within 2025, 2026 at the earliest. So again, that's part of the resource discussion with Darren and others, and Howell's our colleagues that we need to work through.
And just to confirm, Chris, that would be a business justification case, so a single
case.
That will help with timelines as well.
Yeah, it's a lot because of the large case we've had and the periods around the SOC. We've got a lot of the background material there. We've got the footage. We've had an external consultancy that have told us, which have changed some of our specifications. So a lot of the groundwork is there. So,
Darren.
Yeah, thanks. Just to add to that, there was a routine capital review meeting was yesterday afternoon with Welsh Government. We were in the Recovery and Sustainability Board, but colleagues from my team attended. The overview as described was shared, and the sort of joint stepping through with Howell as well. We know government are keen to support this. They are very aware of the quantum of capital that will be needed, and therefore they're supporting that nature of case to come through to as quickly as possible within all the good governance, obviously. And there's a further meeting with Welsh Government on the 10th of October.
So are we able to move to the recommendations then? So endorse option 5 as set out as Chris described it. And we do acknowledge that based on early market assessment, we're not likely to attract private providers. We're going to keep on exploring the opportunities there. And we endorse the fact that we will be sending in one single business case, single justification case to Welsh Government. So we confirm our commitment to establishing a single regional pathology service as set out. But we didn't discuss the external clinical director. Presumably, this is important to lead this change.
This is for the transition. At the moment, neither Hywel or Swansea have clinical leads in this area. So Swansea are looking for a clinical lead for the pathology, but we are looking for a clinical director for the regional service. So yeah, sorry, I didn't mention that. Yes.
And then we look at how we might use any leadership vacancies. We agree to that. And then, of course, we will obviously agree to do what we can to assist the pressure on family. So, Steve, is that enough now for you and Eleanor to keep the reply going forward on this?
I assume the Haldar board has reached the same conclusion, in which case, absolutely. Yeah.
Good, thank you. And Chris, please really our thanks to everyone involved. And obviously we send our thanks and best wishes to Neil as he returns to an island better.
Yes. Thank you very much.
Thank you, Chris. Darren, do you want to take us through Type Now?
Yes, thank you, Chair. Just to appraise board, this paper has been through Performance Finance Committee this week for support ahead of board consideration and potential approval, and that support is provided by the Performance Finance Committee this week. And this paper outlines the business case to reinstate Type Now with low security in the Van Reed. Board members will be aware there was a fire in the premise in November 2024, which took out one of two wards there, the Cedar ward, Rowan ward remaining intact. The Cedar ward has since located itself in our medium secure facility on the same site as well. And there are consequences of that relocation in the sense that our isolated ward is costing more to run from a revenue perspective. And because of the nature of the capacity in this specialist area, more patients are being placed out of area because they cannot be accommodated because we're beds down. So there's a driver there as well. Project board has been formed, the business case has been worked through, and four options and the do nothing option have been considered. And primarily the major focus of this was around options 3 and 4. I can never say this word, but fire compartmentation was key in terms of preservation of patient safety. Fire sprinklers are an enhancement which maintain building safety. The reason why option 3 has been considered as the optimal option here is it is marginally cheaper than the other one by 800,000, which is a lot of money. But equally, the timescales to install sprinklers in both Rowan and Cedar would extend the occupancy of Caswell Clinic to a revenue value of 2.8 million. The consideration has been made in the interest of patient safety and compartmentation, but also in terms of reinstating these facilities to be fit for purpose, have patients removed from the medium secure unit back into the low secure care, which is obviously more appropriate for their needs. There is then a secondary issue, which I'll come back to board on, which is developed as well to allow for extended medium secure placement, which we're discussing with JCC, which will help us in terms of future income loss and mitigation. So the paper is asking board to approve the case. A couple of extra points. This case was drafted to meet board deadlines. It was 5.529 then. That's now 5.935 million. It's gone up by 400,000. There was an error in the contractor spreadsheet, I'm told. But that has been disclosed to Welsh Government, and they're expecting this sum to be the sum that passes through. And there is a section in the paper as well around the procurement and governance process, which we have tested through a compliant framework, which is the South West Wales Regional Contractors Framework. Due to commercial sensitivity, I'm not going to disclose anything else, but their preferred supplier has been identified and tested and is ready to commence this 12 months. There are revenue consequences as well. These revenue consequences are currently in the health board run rate, so the extra 600,000 is a pressure in mental health and learning disabilities, which we've discussed previously, and discussions are ongoing with the Joint Commissioning Committee as the Commissioner about the risk share of the patients who are placed out of the area. We're working actively with them to limit that, for patient reasons, obviously, and family reasons, but also because of financial support. So the balance of the decision is to go with option 3, which would be reinstatement, sprinklers simply in the refitted area, compartmentation in both, and return to normal business within the period. I'm asking the board to discuss and approve.
So has Darren provided sufficient rationale for option 3? Yeah, thank you very much, Darren, for that additional information on that. So are we happy to move to approve the technical business case, and it's now to seek 5.935 from Welsh Government? And then the procurement outcome and award a 12-month construction contract with the reinstatement set out in the end.
Jane, I just raise one thing on the contract, which I raised last year as well when we're looking at these type of contracts, which is where is the clawback should the contractor not perform against the parameters that we laid down? There's nothing noted again in this one. A very minimal risk notification other than potential flooding of the River Ogden. So for me, there's maybe a lack of significant detail in the risks and that contractual implication. And again, how do we measure that they're going to deliver those apprenticeships that they always say they will deliver and they never do?
I'll get you the detail on that. Our contract process is pretty rigorous, but those specific points I'll come back to you on. We have recovered penalties from contractors before. I'll get the specific details of this framework and the nature of this contract.
Yeah. The appendices did make very good reading, very long reading.
Yeah, so you're not reading budgets.
The Darren will reply you with further detail, if that's it. Okay, thank you very much, Darren, and happy that we can move on. Thank you. So we're on to part 5 now, which is always an important part of our agenda on people. So Rena, can I turn to you, please, for the Ward Committee of Labour?
Thanks, Chair. There are 3 alerts from the committee in August. The first Tina's already referred to in relation to the PADR compliance, and there was a particular concern that only 75% of staff have received their annual reviews. So I think there is going to be a particular effort supported by the HR business partners to try and get managers to bring this up to what is a reasonable rate, it seems to me, is 100%, that everybody should have had their reviews. So we will be keeping a focused eye on that. The second alert was in relation to speaking up statement in the Guardian service, and this relates to, in particular, Gosainen. And we've talked about it earlier, but obviously those concerns were raised at the meeting, and there was a particular interest as to the board hearing about those concerns. Obviously that related also to safety. It's going to be referred to quality and safety, but I think events have overtaken us. And the last thing was in relation to the attendance at the workforce delivery group. And it appears that there's been very poor attendance across the piece in terms of the service groups to this meeting. And I know that our Director of Workforce is going to look at the terms of reference and the agendas of these meetings to make sure that we are covering the relevant issues and that we are getting a cross-organisational goal as opposed to really being focused within just workforce. In terms of assurance, there was obviously, we looked particularly at sickness, and we're doing deep dives in each of the service areas to look at sickness because it's obviously of a concern to us. And we had a report on staff health and wellbeing, which is on the agenda as the second item under people. And the last item was in relation to the new leadership and management development programme, which has been introduced, and we endorsed the approach that is being followed here. I think Tina may want to add to that. Thank you.
Thank you, Rena. Tina, would you like to come in?
Only around the sickness absence report, Chair, so if you want me to pick that up now.
Let me just check if there's anything else for Rena on the other. No, thank you. As ever, Rena, very comprehensive update report. And we know that you have a very hefty work programme around this, all aspects of the workforce agenda. So thanks to you and the committee members and staff as well. Thank you. And we can take assurance from your report. So Tina, shall we turn to you then on the staff health and wellbeing update, please?
Yes, so the lens that we took for this report was to make sure we're really clear on roles and responsibilities and accountability for the management of sickness absence across the health board. And that's set out in the report there. So making sure that the workforce and OD function is fulfilling its roles and responsibilities, that the policy is fit for purpose, that line managers have the relevant skills and confidence to tackle absence in their areas and so forth. And the conclusion was that within the resources available, we do feel our health and wellbeing offer for staff is fit for purpose. That if we didn't have that in place, we would see a higher rate of sickness absence and colleagues are accessing that service. We also concluded that there's further work to do from a line management perspective, because that is the key relationship in impacting on people's attendance and wellbeing at work. And therefore we are still focusing on the Brilliant Basics workshops for managers to make sure they've got that right, the right skills, etc. But we also benefited recently from undertaking an audit on making sure people that have met the triggers of the policy have been escalated to a sickness absence review meeting. And that exercise resulted in an increase in referrals to occupational health, but also an increase in formal cases being raised through the HR process. So my recommendation to board is that we continue to have audits and enforcements, if you like, to make sure that the policy is being adhered to across the health board by undertaking similar exercises for that. So that's the main findings of that report. I'm happy to take questions.
Thank you, Tina. Rena, do you want to come back in?
Yeah, I just would endorse the report, but in particular, coming out of the committee was a discussion about whether managers, line managers, have sickness absence management within their corporate objectives. And the recommendation from the committee was that all line managers should have it as one of their priority objectives, that they are managing attendance at work.
Yeah, and I can report that I've drafted a set of corporate objectives, both from for the PADR's sickness absence, but also around budget management. That was they were well received by the Social Partnership Forum last week. So I'm just working that through. So they'll come to the next meeting.
Thank you. Thank you. Anne-Louise.
Thanks very much. I've got one question and one comment which really follows on from what Rena has just said. On page 3 of the report, it's reported that the equivalent of 650 whole-time equivalents are used from bank in nursing and healthcare support weekly. Sickness accounts for 22% and additionality from 44%. That's only 2/3, and I just wondered what the other third was. Numbers didn't.
Come back on that.
So the reasons for use of banking agency are to cover is sickness absence, is an availability. So it would
Yes.
be in those categories that you've got. So what we can provide, if I can take that away and provide a breakdown, if that's okay.
That would be helpful, because as Anne Louisa says, that there's a third of that 650 not accounted for in the text, in the page.
Yes.
That'd be really helpful.
Okay.
And my comment was really, so it follows on from what Rena was saying, that I'm not sure, but perhaps it should be that in the person spec for promotion appointments, the person spec includes an indication that the member of staff who's going to be appointed has knowledge of managing sickness. And I wonder, I'm pretty sure it isn't, whether it's something that is actually included in all managers' interviews when they're being appointed to higher levels. I'm pretty sure it wasn't in my case, whether I'd ever actually dealt with it at all, because it is quite difficult if you're promoted within a department and you are now managing people that you were on the same level with. And I think that's one of the issues, that sort of management is quite hard. But I don't think we are robust enough in either the person spec or the interview to make sure that people know that it is part of the job. And then, of course, it reflects the fact that PADRs aren't being completed. And in the report, it talks about 7 key topics for effective management, but they're only fine if all staff know that they're critical to success and that they can hold their own managers to account for those various things.
I go past then Nicola, and then we'll come back to Tina for a sort of a roundup. Please come in.
Very much welcome the introduction of this new dashboard. Manager can review that daily and it's RAG rated. I think it's really important in terms of encouraging personal ownership, personal accountability for sickness management. I was kind of wondering how robust the data is. Is that robust? And then you've done the audit on the triggers about formal sickness absence reviews. Is that going to be something that's embedded moving forward, or is it always going to take quite a lot of work to do that audit? Because it'd be very effective if that was just embedded within the kind of regular information that was going out to managers.
Nicola, do you want to come in with your question?
Thank you, Jan. Thank you, Tina, for the report. My question's around the increase. I think it's 50% increase for mental health referrals for staff wellbeing in the last 12 months. I'm wondering what work we are doing around ensuring our staff are obviously well looked after, etc., so they don't even need to get to that stage. The other question I had was, a large number of our staff are women. What are we doing to support them, especially it's one of our big topics, so women's health. What are we doing regarding menopause, etc.?
So if I take those questions in order then, so regards to the line management responsibility, that is in the person specifications of job descriptions, but we're not explicit currently around sickness absence. So I think that's a good point to raise. And I think we can also look to make sure the interview questions for line managers include evidence that they've managed sickness absence before, and also appraisals, in my views. So I'll take that away. So thank you for that suggestion. Regards to the data's from our own internal team directly from ESR, and so we're confident in the data. That is subject to the quality assurance, that data, and the triggers are embedded in the policy. What we don't currently do is report those on ESR when those meetings have taken place. So that's something we'll be including going forward. So it's work in progress currently. So we do record the when people phone in sick, the return to work meeting, but we don't formally record those trigger meetings, which we'll be doing going forward. And the last point around mental health support and menopause, we do offer menopause workshops, and we do signpost colleagues through to occupational health to get that support. So I think that's a good resource that we have available. What we need to do more of around the psychological support for colleagues is to do stress risk assessments. So if we know we're working in an environment where even an individual or team members our reporting stress, that you do those stress risk assessments to understand what the triggers are and then the mitigations that we put in place. And I don't think managers are using that tool as effectively as they can do. So we are working on doing a module under the Brilliant Basics to support managers to have that knowledge and skills going forward. So it does need to be improved.
Those questions answered fine, thank you very much. So if we move to the recommendations, I mean, we obviously acknowledge how important the relationship between a line manager and member of staff is, and how important it is as well that line manager, you know, has the right capability to discharge the role. So we know the work that's going on there, and Tina, that you will be actually looking to make the interview process more robust, really, for those in line management, to provide evidence that they have the relevant toolkit, really, or skill set to discharge the role. And then we'd also want to endorse a focused approach to sickness absence management, as Rena's also described, and the HR business partners will be helping managers to implement that. Thank you. Is that okay? Thank you very much. So should we have a 10-minute break there? And Pat, as the Vice Chair for Audit Committee, if you could pick up the September meeting.
Yeah, I think Nuria handled July in the last meeting. Only one alert really, which was the internal audit of the strategic equity plan, which was a limited assurance report, mainly around governance arrangements, action plan formulation, monitoring, reporting, those aspects. So it was referred into quality and safety as well, and I know Jean's picking that up.
Jean, yes. Anything on that?
No, it was referred into me 2 weeks ago.
Okay. So, right, so I see we're picking that up the audit. Okay, thank you, Pat. No other alert that audit committee wanted to. I'm sure you will be feeding into QSE.
Yeah, I was about to say, we had a really good conversation in the audit committee where we tackled the governance related aspects. And as you said, Pat, there's a plan in place for October and November through to management board to take positions forward. So plus reconstitute the different elements of the plan as well. So yes.
Thank you, Richard. It'd be really helpful. Additional details for Jean there as well. Anna Means, would you like to take us through the mental health legislation?
Yes, thanks, Jan. There's one alert which relates to Mental Capacity Act training. Most other health boards have that as part of the statutory and mandatory training, but we don't. There is an issue insofar as it's difficult to tell from ESR who has and who hasn't done the various levels of Mental Capacity Act training. And it is, I think, something of a barrier to speedy discharge, because quite often, and I don't underestimate the complexity sometimes that patients are facing and the involvement of various agencies. But it just seems to be missing a trick not to have a wider an expansion of Mental Capacity Act, so everybody has a good basic knowledge, because the questions that come in, and I know from my past job, tend to be the same questions every time, but with a slightly different scenario. So it's a basic underlying misunderstanding of what the Mental Capacity Act involves. So it was simply to put it on. I'm not going to keep putting it on as an alert. It will remain there in the background in the future, because I don't think there's any move at the moment. There's certainly no government funding to support making it part of the statutory and mandatory training. And it's a pity that ESR doesn't capture it, because it only looks at who does it as opposed to a proportion of the whole population of the health board, which isn't helpful for people who need it. And you'll see under number 3, the assurance, it says mental health measure monitoring report, should we state what we're assuring? I could. It would be repetitive because it's the same thing, but at the moment there is no non-compliance with the measure, the Mental Health Wales Act measure. So that's an assurance that we look at the information, the data that comes in, and there's no non-compliance.
Tina, do you want to comment on the ESR question around Mental Capacity Act training?
Yes. Yeah, so there's further work to do around, there's a module within ESR that records all of the mandatory training and essential role training. At the moment, we haven't got it set up as described to allow us to record the various levels of that training. So they're, levels 1, 2 and 3, which are for different staff groups. I've been working with the team to look at other options available. There are other systems that you can use that allow you to do that reporting, but there's also a new ESR system being procured nationally, and so we're waiting to see whether that's got that functionality before we spend money elsewhere. So it is something on my radar, and I'll bring back a timeline around that through the Workforce and OD committee.
Thank you, Tina. Do we know the timeline for that procurement?
So the national, we're looking to be one of the first implementations of the new national system in Wales. So we've been told it's been between 12 and 18 months' time, but that's yet to be confirmed by shared services. But that's, so we're anticipating April 27.
Thank you, Tina.
So one of the problems is, and one of the reasons that it's been brought as an alert, is that we do get information about the training that is offered, but the poor numbers that actually attend that training. So training is there, and it's not taken up. And the problem is that the best interest assessors, and you've heard me bang on about best interest assessors before, don't have the capacity to undertake that ad hoc training when somebody comes and says, can you help on this particular?
Thank you. So Tina, can we have a look in the short term then at take up of what is there to make sure that we've got capacity and capability really where we need it? Thank you.
Yeah, will do. I'll take that action. Yep.
Thank you. And anyways, on the mental health measure monitoring, you want more detail on what we're actually taking assurance on.
It's usually the same each month because of the nature of the measure and what it's monitoring, and we have the data. So all I'll do is I'll just expand that to say that there are no concerns regarding overall compliance with the Mental Health Act, Mental Health Measure Wales Act. That's all that really needs to be in that section, rather than the question mark about what we should be doing.
Okay, that's fine. Thank you. That's great to have that. Thank you very much. And then Hazel, you're going to pick up the RJC?
Yeah, so the Regional Joint Committee last met on the 18th of August. There were no alerts from the committee. There are areas to advise the board in terms of the AI presentation, urgent and emergency care committee supported priorities identified in the workshop, and pathology I won't cover because that's been covered on the board already. Clinical services planning, there were advances in orthopaedic and eye care, noted including joint theatre utilisation and a single waiting list as well. Other areas covered in the meeting were digital and data, finance and contracting, research, innovation and regional health economy. And then in terms of Assure, then the committee was through with the board that the committee was operating within the governance principles underpinning leadership transitioning and work program development.
Very much.
I'd like to note, Chair, if that's okay. In joint committee, we noted that the first regional orthopaedic list for Hywel Dda surgeons in East Talbot Hospital was due to take place in September. We're going down to the wire. It's scheduled for Tuesday, the 30th of September, and I understand it is nailed to the wall. So it'll happen.
Oh, that's great. So we look forward to meeting us next time. And that we got further exchange going on. That is great. Okay. Any questions or comments? Steve?
Just a piece of information, my informant in the Haldar boardroom tells me that they also approved option 5 in the pathology claims. Obviously, is.
That is good news. Thank you. I know Chris was trying to find out. Thank you, Steve. That's great. So thank you very much. So we can consider and support the progress we've made. And then can we ratify the approval of the new governance arrangements and the direction of travel of the subgroups? Thank you very much. And as I say, we look forward to the conclusion of the work on single path solution being our flagship that we present to the cabinet secretary at the year end. So that's great. Thank you very much. So we then come on to another really important item on our agenda, progress. Also, well, how remarkable. Yes, go on, please, you carry your paper.
Okay, so in terms of the corporate governance report, this is the usual report that comes to the board. It sets out the matters we've considered in committee from a transparency perspective, Welsh Health Circulars and the Common Seal, and the business cycle. We've also developed a protocol for observing and forward committees as well, and that's attached for members' information. But we are attaching for approval the committee's annual report for the board and also the interim arrangements, amendment, to the model standing financial instructions as requested by Welsh Government, primarily relating to the legislation change in terms of procurement.
Thank you, Hazel. Are we happy to receive all the information that Hazel's report has set out and approve the annual report from the committees, which again does demonstrate the weight of evidence really that the full board has on its committees, and then approve the interim amendments to the model standing SFIs. Okay, thank you very much. So that, Hazel, that takes us on to board minutes. Is there anything from the minutes of the 31st of July meeting, please? Or can we take them as a true and correct record? Thank you. And then we've got the action log.
Yeah, in terms of the action log, number 1 is been open, and number 2 relating to vaccinations. We suggesting that this is closed down because there'll be regular updates provided to the Workforce and OD committee and then to board via the 3A report from that committee. Number 3, that's been actioned. Number 4, this is a bit more complex than we thought, and we've been discussing this, and we suggest that we take this through the next Population Health Committee and then report it up to board via that committee. And then the 5th one, waiting times, this is a focus piece of work being undertaken in October, and we expect the update to come to November board, and then we can close it down. Number 6, there's a report going forward in committee in terms of the outstanding audit actions, with a particular focus on those that relate to patient safety, and that will be reported to board then via the 3A report. Number 7, then work is underway. We anticipate closing that down in November, and 8 has been actioned. And the 9th one, the last one open, then we're setting up the meeting for the committee's chairs and lead execs, and we're looking at that to be held in December.
Thank you. Any queries or questions for Hazel? No, thank you. And Hazel, we thank you and the team for going through the action log in a diligent way that you do. Thank you. So then we've got a range of items for noting there. Those that we want to put into the public domain, just to make sure they are on the record and not go through them. But Pat, was there anything you wanted to advise the board following the stakeholder reference group meeting?
No, well, yes. Just briefly to say that we had a very effective meeting, and we then had a good meeting with yourself and members of the board. It was very welcome. And so that I think slowly the SRG is starting to become an effective committee. We also had, there was a meeting today, in fact, of the Regional Health and Wellbeing Group, which sends delegates to the SRG. Obviously, I couldn't be there because I was here, but I had an email to say that 2 more people put their names forward to join the SRG. So, yeah.
Well, that is good news. Yes, great. Thank you, Pat. In this section, under 7.2 in the Welsh language standards, there is the annual report there for 2025. How we can find this group that for publication. And then also the Speaking Up Safely annual report, as I mentioned earlier. It's a report from the Guardian Service. So can we take assurance on that? Rena, would you like to come in there?
I just want to say that this month coming in now to October is Speaking Up Safely month. They're doing a bit of a campaign around it. And myself and Tina are doing a bit of a video to release to staff to encourage them to speak up safely.
Oh, that's really good.
Yeah.
That's lovely. That's fun. Yeah, that is really good. And of course, when we come to perinatal committee as well, and as we had in Go Simon this morning, and as we heard earlier, when 2 members of staff from ED came to the board in January, hearing from staff, enabling staff to speak up safely is so very important to us. So that's great. Great. Thank you very much. And then just to say the bits and pieces I set out there that I've been doing since the last report to the board for people to note. So while we wait again for colleagues to come, is there any other business? I've not been alerted to anything, but is there anything that's occurred to anyone as the day's gone on? Anything you want to flag now rather than wait for another? No? But we won't do the review of, is Kathy there?
Yeah.
Oh, Kathy, are they there? Are they all online? Yeah. So are we ready to go? So hi, Catherine. Hello, hello, hi, Sharon as well. Anybody else we're waiting for? That's great. So Leslie then, I can hand to you now then on perinatal committee. Thank you.
Thank you, Claire. And I know that we have had some updates from quality and safety guys, but just for due diligence, if I just take you through the highlights of the report. So this is the first report to board outlining our programme of work and has previously been to Quality and Safety Committee. In respect of governance and oversight, the Perinatal Committee has been established to provide assurance on maternity and neonatal services following escalation to level 4 by Welsh Government. The inaugural meeting was held in June and a subsequent meeting in July. The independent review published in July 25 identified 10 key recommendations, which are now being actioned by the Perinatal Steering Group and Oversight Panel. In respect of progress on the independent review recommendations, one of the immediate actions in relation to intensive care and remote radiology, I can confirm those are underway. The single point of access maternity triage is planned for March 26, pending recruitment. The All Wales Muse and Fetal Surveillance training is already implemented. Project management support has been sourced as currently advertised with good interest in that post. Workforce and training to report that we are Birthright Plus compliant. Training compliance is high and meets compliance criteria across prompt, gap grow and neonatal life support. PADR compliance is 83 and mandatory is also on track, achieving over 85%. The alert earlier which we discussed is in relation to the neonatal consultant vacancy, which is from September and requires urgent recruitment. In respect of quality and safety, there aren't any current negative outlier flags. There's been a positive inspection from Health Inspectorate Wales in May 25, and all actions I can report are on track to complete. 10 of the 14 have already been completed and closed. Surgical site infection rates have improved following targeted intervention by the team, and late onset sepsis rates have decreased, and we're no longer a negative outlier. HIE rates have returned to a benchmark baseline level when we've compared those across the UK. And detection rates small for gestational age babies via the GAP programme exceed national averages. In respect of engagement, a comprehensive engagement strategy has been developed, building on the independent review outreach and transition to maternity voices to maternity and neonatal voices is underway. We've got a pilot site up and running for the NFS core questionnaire with a 46% feedback rate. This data has been used to inform service improvement and report via the service group's governance process. And the key around this is rapid responding to women's feedback within the service group. Data and digital transformation, Vaginote's digital maternity record is due to launch in March 26, enabling consistent data collection and benchmarking across Wales. So if I can just draw the board to the recommendations, to be advised that the project management support is being developed, immediate actions from the independent reviewer in progress, to be assured that the maternity workforce is birth rate plus compliant and well established. Training and PDR compliance are on track. There's no current negative outliers indicated, and to be alert of the single point of access maternity triage is depending on recruitment. And I've already mentioned the neonatal consultant vacancy is needed. And I believe our colleagues have joined from the service group.
Thank you. And we are bringing the full improvement plan to the November board, is that correct? Yeah, thank you on that. So Kathy, Sharon, did you want to add anything before I open it up for questions or comments?
Just to say thank you, Chair, and to the members for receiving our report today. We always welcome the opportunity to share the progress that we are making and the quality improvement programme that we have in place for our further developments following the publication of the independent review. Just a thank you for receiving our paper.
Thank you very much. I open this up for questions or comments then. And Abby, afterwards, we'll just say something about the meeting we had on Monday evening with members of the Swansea Bay Maternity Support Group. We'll take questions on comments on the paper first. Martin.
Just a small comment, really. Is all this positivity now within the services must have a greater effect on the staff working there, really, and that must go a long way in improving the quality of the services that's being worked in on the unit, and I guess helping senior staff as well, I guess. So congratulations, well done.
I'm not sure Kathy would come in on that point.
Kathy?
Yes, thank you very much. And you're absolutely correct. The team are very proud of the work that they do. So when they start seeing the results coming through that show the impact of those improvements that they have been making, it does have a positive effect on the staff morale. And it's a very busy time in maternity services at the moment. So when they get the feedback through from the families, which is the most meaningful feedback that they like to receive, and we have lots of that coming through. And it's really encouraging to see that the public are acutely aware of the impact of the report on our staff groups and are keen to write to us and tell us about their experiences, both where we have learning to make or when they've had an exceptional care from us, and we're really grateful for that.
Nicola, would you like to say something?
Thank you, Jan. Thank you very much. It's a wonderful report. My question is, I welcome the single point of access for maternity triage, but it's not launching until March 26. So what are we doing to support expectant mums in the meantime?
So what I can say to you is we've implemented BSOTS, which is a nationally recognised triage system in maternity services and is also highlighted in the RCOG good practice around triage in maternity services. That's already in place and that is having good effect. So the women are coming via one pathway. The single point of access maternity triage is very much reliant on the new digital system Badgernet, which is rolling out, and the programme sits within Badgernet. And we will be going live with that on the 31st of May, which is why 31st of March, sorry, which is why that date is in there for the single point of access triage, because we'll have the right IT mechanism in place then to capture all of that work.
That helpful, Nicola? Thank you. Richard, there's a reference to the immediate actions, one around remote paediatric radiology reporting. Do you want to say something a little bit more about that?
Yes, thanks, Chair. So one of the recommendations was around an urgent need to provide full-time paediatric radiology service or a full-time reporting service. And it's an example in the many complexities of the service and how we get the right level of support in. This has proved to be something that's taking longer for us to resolve and find a suitable solution than we would have wanted. But nevertheless, I suppose it also highlights our determination to get that solution right. This isn't just about paediatric radiology. So we currently have, this involves 3 different strands. Paediatric radiology, it's neonatal radiology in babies, and it's cranial ultrasound for neonates as well. So that's ultrasound scans of babies' heads. And all slightly different. We currently have 1 full-time paediatric radiologist in Swansea Bay, So to scale up our service in order to provide a 24-hour service is not going to be feasible for us in the short or medium term. And so what we've done is we've looked to scope out the possibility of having third-party providers provide that for us. We know of a external agency who could do that for paediatrics, checking the detail on neonates. On the cranial ultrasound for neonates, that's slightly more complicated. Generally, cranial ultrasound is done by the neonatologists themselves and is reported by the neonatologists themselves. What we currently don't have is a system of quality assurance on those scans and the outcomes. In some places in the UK, the neonatologists do the scans and radiologists do the reporting. Clearly, we don't have that availability for us either. Unfortunately, that external supplier can't provide that element of it. And so we're exploring whether there's an arrangement that we can come to as a networked arrangement with a partner who might be able to support us with that. We don't believe at this stage that that's likely to be a partner in Wales. So that's going to take a little bit more work to work through. But they're all in progress. We're hopeful that we'll get a solution to the paediatric radiology and neonatal radiology by an external provider soon, but being worked through the cranial ultrasound is going to be slightly more complex.
Thank you, Richard. That is really helpful detail there, just how complex this is. Anne-Louise.
Yes. On Richard's point, is there that sort of service available in England, that there's a centre of excellence where there are neuroradiologists who can deal with the neonates?
Possibly. So there are several avenues of contact. The individual who came and was part of the independent review works in a unit where radiologists provide that. I don't know. We don't know yet whether they support us in doing that reporting or whether it's more practical to have someone that's closer to us as an MDT type arrangement. That just needs to be worked through in a bit more detail.
Because specifically on the issue, when we were really fortunate, the Chief Medical Officer in her early weeks came to visit us, and she met with Kathy and Sue Joy and Madhu from the service board. And you did a great job, Kathy and team, in terms of talking about the work and the review. And the Chief Medical Officer asked, like, which are the most difficult recommendations to implement? And this was one of the ones the team talked about. And she was very supportive in terms of if we can help with a wider conversation around some of these really small specialist and fragile services. How do you get the assurance? And is there or Wales, or as you were alluded to, Anne-Marie, actually linking to other centres in England, that there's what do we need to do in the short term and what can we do as quickly as possible? And then there is also what becomes a much more sustainable solution. And that is it's really helpful that the Chief Medical Officer signalled to kind of support and intent for that kind of mode of working moving forward.
That will be critical to support the neonates who are born in maybe adverse circumstances. That would be good. The other question I had was to do with the recruitment of Band 5 newly qualified midwives and whether that's dependent upon the financial situation at the moment, whether we have to wait until next financial year.
Kathy, do you want to update on that? Because we've agreed to take, haven't we, the midwives coming through?
Yes. So we just we have 10 newly qualified midwives due to start with us in the autumn of this year now. HEAW has a contract with All Wales around student midwifery recruitment, which is that all health boards must commit to recruiting newly qualified midwives at 22.5 hours. Now that is not equal across nursing. They all get full-time employment on qualification. However, for the majority of health boards, when they onboard the newly qualified student midwives, because of natural attrition, we always increase their hours very, very quickly. It's important to them because of the financial hardship you described, and Louise. And we recently had an All Wales meeting in which Carvel came to talk about the economic crisis for some of our midwives. And of course, Carvel can only be applied for once you become qualified. It can't be applied for through the student route, sadly. So we are acutely aware, and all of the health boards in Wales, I know, are working really, really hard to try and secure full-time employment for our newly qualified staff, because it's important around continuity after qualification so they can consolidate their skill set.
To answer your question, Annalise?
It's really whether the triage system, and I appreciate a lot of that relates to BadgerNet, can go ahead in the absence of the recruitment of those midwives.
So we do have a plan around that, Anne-Louise, which is why the business case is being worked through. The commencement of the triage line in March is going to be very much prevalent on the recruitment of these newly qualified midwives and the training of our teams who will work in that, and that will give us an opportunity to, through our business case, apply so that we can employ these full-time in order to give us that workforce that we're going to need for that.
Anna-Louise, if I can just come in. So we are recruiting the newly qualified midwives September, October, so they will be starting with that. There is only one intake a year for midwifery students. So we will review that in the summer going into next year. But we have been incredibly reliant on our streamlining midwives coming in. So I wouldn't anticipate that to change. So we are taking our full cohort this year, and we would anticipate to do the same next year.
Correct.
Lovely. Thanks very much.
So Abby, would you like to just say something in general terms around our meeting on Monday evening?
Yeah, thank you very much, Chair. Colleagues will be aware that when we received the independent reviews report and recommendations in July, one of the things we committed to was to continue to hear the stories from some of the families who've had a poor outcome or difficult experience as a result of our service. And on Monday, Jan, Liz and I met with the Swansea Maternity Support Group. It was a really important opportunity for us to meet with some of those people, some of whom have engaged in independent review and others who haven't. It was a really useful opportunity to again to apologise to those individuals who may not have publicly heard that in terms of the impact we've had on their lives, to hear from patients and families and service users directly around some of their experience. And it was just reiterating really how very important the independent review has been in terms of the thoroughness of it and the depth of which it went to. So all of the issues they raised are contained in the recommendations and the themes. Really, we have some work to do some reconciliation for individuals who are in a process of complaint, an investigation or illegal outcome. And there's something about as a woman, family member, understanding that process is really tricky to understand. And some people think they're in one process and they're in a different process. So and again, that's part of the recommendations about helping people understand what those processes are. And they might be running in parallel and different processes, and understanding that and communicating importantly. The importance of just saying sorry when something has gone wrong. We heard from one woman. It was really good to engage, and she's followed up with an email to Liz, and Liz has been in touch with her. Actually, that's what she wanted to get closure. We haven't done that, and we've gone back and looked over. That is so important, and hopefully that will enable her to move forward. What was lovely is that we had 3 little ones in the room, so it's not all about babies that don't survive. It is sometimes about the poor experience and the trauma that a woman and their family might have experienced. But we had 3 lovely, a baby, a toddler running around, and a little boy who was extraordinarily well behaved, probably past bedtime on a Monday evening. But for me, that was the kind of the whole point. This is about making sure that we do everything we can to ensure women and families can have a safer experience and come away with a lovely new family member. We know that doesn't always happen for everybody, and that is not necessarily because we've done something that was not the right thing to do. But it's about making sure that we support those people appropriately and properly, and that we can help them understand what happened as much as possible, recognising sometimes that there just may not be the evidence. But again, it's all about communicating and talking and taking the time to work with families through that, and recognising sometimes they need to come back a long time afterwards to ask those questions. And I know that Liz has had some contact with people who had a bad experience many, many years ago, and they still haven't had some closure. So we will do what we can to investigate and look into cases that are well out of time. And this thing about there's a time when you have to make a complaint or go through a legal process, and something about, well, there can be exceptions, and let's work with people around kind of trauma-informed practice. So it was again a really just useful opportunity to apologise to those women and families, to have the conversation, to hear it firsthand. But also there was some really constructive comments as well about recognition that we can't do it all in one go. And some of it will take some time to impact. But clearly it's managed, as I said, it's managing those families who are still in the process and need our support, and a really compassionate and trauma-informed response to that, as well as saying actually the benefit of so many people contributing to the independent review and the way that they've synthesised that into the key 10 recommendations, and the learning from all of that is our commitment to focus on those things and drive through the improvement and changes. So we will never satisfy everybody in terms of how quickly we can move at pace with this, but I think there were some useful suggestions. And obviously Ken Sutton was in the room as well, and Ken's going to continue to work with us on the family and engagement work. And I know we've got the learning event on the 19th of November, so that's looking like a really good programme. That will start with patient and family stories in terms of experience, which I think is absolutely the right thing to do. And obviously we've now got confirmation around the national assurance work, and indeed the Cabinet Secretary's independent appointment of an observer sitting on our oversight panel as well. So I think that was really helpful. And it was great that Ken was in the room to connect with some of those families and women who want to engage. And there are some people we'd like to follow up with around some really good suggestions they had around how we can improve things. So again, really, really worthwhile and helpful always to hear directly from women and families around their experience.
And we did extend an invitation to the group to engage in the work that Ken would be leading, remodelling our family and community engagement work and our approach, as one of a number of constituent parties we will have in that work. So hopefully, at least some of those in the room will come forward and engage with us. So that would be really helpful. So shall we move to the recommendations then? So we advised and we acknowledge that plans for project management support now are well underway, we think, in terms of making sure we've got a formal project management approach to the improvement plan and its implementation. We know that we've introduced a SOC between intensive care and the neonatal unit, and then Richard's outlined the progress we're making. So if we can acknowledge the progress that we have in terms of the remote radiology reporting, the different components of that. And Richard, if you can keep us updated, we'll have a further report on that. So we take assurance as well from the positive contents of the report and the indicators that we are able to offer. And Kathy's explained with Sharon on how we are going to be moving towards the single point of access from March 2026. And Kathy, perhaps you could supply us with a further briefing note that we can include and send round to board members as well on that. And thank you both for joining us this afternoon. And, there's been significant progress made. We were already making progress in the months before the independent review was reporting. That has been a catalyst for increasing progress on improvement. And we are looking forward now to receipt of the formal final improvement plan that will actually help take us through to exemplar status for maternity services and neonatal services in Swansea and East Portal, but which is what we're aiming for. Thank you. So diolch yn fawr iawn am eich amser. So thank you very much for your time and, go with that best wishes for continued improvement. Thank you. So that does bring our meeting to a close. Andrew is our rapporteur for today, and Andrew will summarise the level of effectiveness of the meeting since we started at 10 o'clock. So Andrew, over to you.
Okay, I've just made some initial notes and I'll tidy them up later. But I thought the responsibility for the board were set out clearly and the context set for decisions and discussions that we needed to make, notably around assignment and finance discussions where we understood how and the context in which we were making the decisions. Papers are more manageable with the use of the reading room, I felt, and they're now numbered in the reading room, which also makes it easier to relate to the documents, which is good. But I did feel sometimes there was a little bit about, weren't sure that there were other documents related to that, and there might be an idea to just note that on the papers. The deciding decision was an example, I thought, of the board balancing the risks appropriately and dealing decisively with the issues that arise. And we had a good discussion around that, reflecting different viewpoints. The agenda represents the scope of the task force responsibilities, particularly with the development planning and partnership report, which shows the wide, what's the right word, outreach we've got right across different organisations. And also the rolling update, the item on community pharmacy, give us again a broader picture of all those responsibilities. I felt there was a conscious effort to think and consider the medium and long term, despite the immediate pressures, which is good. And the patient story really helped to ground it into why we are here. And it's so encouraging to get that perspective at that time. The integrated performance report provided a sharper focus, I think, than previously. And certainly the reports are easier to digest, which makes it brings it alive a little bit more. And the business case I felt were comprehensive, making the decision making easier because it covered off a lot of the questions around where we were. And then finally, I just thought that the committee report seemed to be developing well and are more timely and really evidencing the emphasis that we've got on the committees doing a lot of the hard work in getting behind the detail, and then again just alerting and bringing to the board the decisions that need to be escalated. So getting that right level of where decisions and scrutiny needs to sit. Right.
Thank you, very comprehensive. Anybody want to add anything immediately, or do you want to think it over and come back, Jill?
So an update, thanks to Deb, no glycerol drinks are sold anywhere in our country.
Oh, that's great. So Jean? None of these drinks are sold in our premises.
It's slushies. Yes, slushies.
No slushies.
Yeah. I did see that, so that's great. Thank you very much. So that's a really prompt response. Thank you. Any initial comments, or as I say, people going to reflect and key anything else? Andrew, thank you very much. You've done such a great job. We can come back if necessary.
We're doing a poor job next.
Close twice, I think. There we are. Oh, so we close the meeting now then. Jill from Ariane Hughes and Mike from the ADI. Thank you all very much for your contributions. It's been a really wide-ranging, a serious agenda today with some very weighty issues. But I think we've come through and explained the rationale for the decisions we made quite well, hopefully. Thank you. So we'll have
Sorry, one very quick thing that Nicola messaged me about as the chair of our organ donation committee. It's organ donation week, and there's a lot of great work going on in our organisation. So you'll see the buildings lit up in the colour that reflects this. And I'm sorry, Jen, I meant to mention earlier under any business, but just to say we've got a lot of really good work. It's really important in terms of supporting people to both donate and be in receipt of a donated organ. So really great news there. Thank you for raising it, Nicola. Thank you.
Dee, did you want to say anything?
You can set your preferences for organ donations through the NHS Wales app as well. So don't mind if it's about to keep the eyes, we might be reporting on.
Amal, would you like to say something?
Say thank you, Chair, for inviting me, and thank you to all the board members for allowing me to sit in this meeting. Very informative. Thank you.
Thank you. And we'll have a feedback session in a couple of weeks, and we can go through and watch the recording, and we can talk it all through in terms of Thank you. So we'll have a short break now, and then the board will reconvene in committee.